All right, so good evening, everybody. Again, we are pleased to welcome Dr. Helen Dimaras to give her global health seminar to us tonight. She is a scientist in the Child Health Evaluative Sciences program at the Sick Kids Research Institute and the director of Global Eye Health Research in the Department of Ophthalmology and Vision Sciences at Sick Kids. Also, she's an assistant professor. I think you're an associate professor actually now.
Right.
I
Yeah.
apologize for that. I have an old version
Okay.
of this. At the University of Toronto in the Department of Ophthalmology and Vision Sciences, Faculty of Medicine in the Division of Public Health. And she also holds an honorary lectural position in the Department of Human Pathology at the University of Nairobi.
Great. Thank you so much for having me speak to you today. It's my pleasure to speak to you about my exciting, really passion project focused on addressing the global retinoblastoma survival disparity. Just an outline of my talk. I'm going to give you a short intro to me and my research program, just so you know where I come from and how I ended up in this field. And then I'd like to tell you a little bit about retinoblastoma and its relevance to global health, and really focus the presentation on some work in Kenya with the Kenyan National Retinoblastoma Strategy and some research and patient engagement activities that are improving survival and outcomes from retinoblastoma there. And I'm very happy if any of you have questions to interrupt me as I speak, or you can leave your questions to the end, your choice. So my career journey is a little bit different than maybe most of you. I started studying molecular and medical genetics in my undergrad degree at the University of Toronto. About the time that I was studying was when the human genome was first uncovered, and there was a lot of excitement around it. For me in particular, I was excited about the prospect of knowing the genome for cancer research. And I followed up with grad studies in molecular and medical genetics focused specifically on retinoblastoma and how it develops in the child-infant retina through loss of RB1 and acquisition of other genomic imbalances that lead to malignancy. This whole time, though, working with the principal investigator whose lab I was in was a clinician. And so I would hear about clinical cases and the state of retinoblastoma around the world. And in particular, what stuck out to me was this awareness poster on my supervisor's door from India showing this protruding mass in the eye of a child that we never saw in Canada. Retinoblastoma diagnosis never got to that point of being so late. And so in my early studies, I was aware of this imbalance globally in terms of outcomes of retinoblastoma. And it struck me as unfair that here I was studying the really nitty-gritty details of how this tumor develops and the little details of which gene turns on or off or is more prevalent or less prevalent in order to make better therapies and cures, but perhaps what I was working on would never actually make it to the children who needed more basic support. However, I was a molecular and medical genetics student, nothing really related to global health or international health, which it was called back then. And so I started studying a few extra courses at the School of Public Health, understanding the history of international health, even here at home in Canada in terms of Indigenous health, and understanding health inequities a little bit more. And after I got my PhD, I had the opportunity to join the Sick Kids Department of Pediatric Oncology and work with the team implementing an international clinical trial on high-dose chemotherapy for retinoblastoma. So I got to use what I knew about retinoblastoma and sort of enter this clinical sphere and dabble in global health. At the same time, my former PhD supervisor was starting to partner with clinicians in Kenya to do some capacity building, which I'll tell you a little bit about. And I had the opportunity to be involved in that during my postdoc. And through those experiences, really, I met people and generated ideas for independent research, which led me to where I am now as an independent researcher at the University of Toronto and with a lab research lab in the Sick Kids Research Institute. So that's my career trajectory and where I am and what I do. And my lab is focused on retinoblastoma as a model disease and looking at it through the lens of global health, using patient-oriented research methods, and still looking at genetics and how to deliver optimal genetic testing and counseling, which I'll tell you a little bit about today. So I told you a little bit about the relevance of retinoblastoma globally, but I want to focus a little bit more closely on the definition of global health. And you're all probably familiar with this definition from the Lancet, published in 2009, which states that global health is an area of study, research, and practice that places a priority not just on improving health, but achieving equity in health for all people worldwide. And so this definition really focused on the issues of global health as not actually being, they're beyond borders. They're things that affect us globally, everywhere, that they involve many disciplines, and actually the challenges require interdisciplinary collaboration beyond the health sciences, and that this goes beyond just clinical care and also looking at population-based prevention. And so this issue of health inequity is very prevalent in the global childhood cancer community. And what we see around the world is that although many of these cancers can have high survival in high-income countries, more kids die from cancer in low and middle-income countries. And survival rates can be as low as 10% in low and middle-income countries, but in high-income countries, they can be as high as 84%, and for retinoblastoma, even higher. And so taking a step back to look at retinoblastoma, this is what it looks like. I'm not sure what backgrounds you all come from, so I'll give a basic intro. Sorry if you already know this. So more commonly, retinoblastoma first presents as a white reflex in the eye, or leukocoria, shown in this photo here. It's the most common intraocular eye cancer in children. It has an incidence of about 1 in 16 to 1 in 18,000 live births, and it's highly curable when diagnosed at this stage, and the cancer is contained within the eye. It's actually the first cancer that was shown to have a link to genetics. And so it can be predicted in affected families when they carry a mutation or an abnormality in the RB1 gene, in one allele of the RB1 gene in all the cells of their body. However, a subset of retinoblastoma is just unlucky enough to have that mutation happen sporadically in the retinal cell, and otherwise they're normal and do not have this heritable form of the disease. Those with the heritable form of the disease have higher risk of passing on that mutated allele to the next generation. And they also have a lifelong cancer risk. So they're more prone to getting cancers later in life, especially if they've been treated for retinoblastoma with radiation therapy. Their lifelong risk of cancer is even more elevated. This is what it looks like. Shown at the top are the different stages of disease. And so you might be able to see in this RetCam image a very tiny tumor, stage A, or by TNM classification T1A. This tiny tumor would not be visible to the naked eye, most often looking into the eye. That kind of tumor would be seen because we're expecting that child to have a tumor, like perhaps their parent did, or perhaps their genetic testing showed that we should be waiting for a tumor to develop in that eye. The leukocoria would be more evident at one of these B, C, D, or E stage tumors. These are all intraocular. However, the E stage tumor, this one is showing high risk of extraocular spread. And so oftentimes an E eye would be enucleated, whereas the earlier stages can be treated with a combination of focal therapy, laser or freezing cryotherapy, along with systemic chemotherapy or newer modalities of local chemotherapy. And as I mentioned, that EI would be enucleated. Extraocular tumors are rare in high-income countries, but as shown here, they are associated with a delay in diagnosis. And our early data in Kenya showed that a 6th to 11th month delay is the difference between an intraocular tumor diagnosed a presentation with this leukocoria versus this extraocular mass, which we often saw in Kenya. And so this is what happens, is the outcome of that health inequity. And that late presentation and that extraocular tumor, which is not curable, is why we see this retinoblastoma survival disparity worldwide. And the reason why more children are dying in low and middle income countries as well is because more of them live there. So 92% of children with retinoblastoma live in resource poor countries, and only 20% on average survive. And that's because there's more children there, there's higher birth rate, higher populations. In high income countries, resource rich countries, only about 8% of the world's children with retinoblastoma live, and survival is up to 96%. And so this is a health inequity. Essentially, its definition is that these are systematic differences in health status between populations. They're socially produced, and they're due to unfair and avoidable factors, which means we can fix this. And so today I want to focus on some ways we're looking at establishing what the root causes of those health inequities are, and looking at systematic ways of intervening to address those inequities and fix this imbalance. So for retinoblastoma, the things that contribute to the health inequity are a combination of factors. You can start right from the beginning of seeing that perhaps there's a limited availability of health services. Perhaps the health services are available, but they're in varying quality. They may be available and high quality, but there's some other barrier limiting access of those who need it to getting those healthcare services. The other aspect related to retinoblastoma is public awareness of the signs and symptoms of cancer. So knowing that that white reflex is actually a cause for concern, or maybe even just having the ability to Google it, to learn that perhaps that's a cause for concern, can be the difference between a parent seeking support or help for their child versus ignoring it, because it doesn't cause the child any problem. They're not complaining, they're not in pain. And so that limited awareness or barrier to understanding what that sign means can lead to late diagnosis or misdiagnosis. And this can also happen at the level of the healthcare professionals, from primary care right up to tertiary care, where limited training of healthcare professionals to recognize and diagnose retinoblastoma or properly refer can also lead to later diagnosis, misdiagnosis, or a missed opportunity to apply evidence-based care. And so any one or combination of these factors can lead to that health inequity, the poor survival from retinoblastoma. So just looking at the first one in terms of limited availability of healthcare services, the very basic low-hanging fruit that my team sought to uncover was, where are children with retinoblastoma able to be cared for around the world, and what's available for their care. So retinoblastoma management is multidisciplinary. It does involve the ophthalmology team as an eye cancer, but of course that happens in a very coordinated fashion with the oncology team. Because some management is surgical, pathology is important there as well, when the eye is taken out to see what's the extent of disease, and has it actually invaded any of the ocular structures, and perhaps at risk, giving the child a risk of metastasis. Nursing and social work are really important as well to help the families manage clinical care and access to resources or insurance if necessary. Child life is another aspect of psychosocial care where families and children are taught ways to cope with the disease and cope with the various aspects of care. So child life would sometimes help children understand and through the use of medical play, what's going to come next in their care. Genetics is important because, as I mentioned, having the genetic testing can distinguish between a heritable or non-heritable case and identify risks in the rest of the family or in future members of that family. Radiology is important, as well as radiation oncology, which I didn't put here. Imaging right up front, so taking photos of the eye, ultrasounds, diagnostic imaging, very important for initial diagnosis. When that eye is surgically removed, an ocularist is important to fit the child with a prosthetic eye and ensure a cosmetic appearance that helps the child and family cope with the surgical removal of the eye. And all this requires a coordination of care through administrative support. All the specialized equipment and tools used for diagnosis and management require a certain level of tech support. And missing these, which don't quite fall into the clinical care, are sometimes missed in global health projects. We don't realize the importance of this, this work when we're developing capacity building projects. And also, palliative care is important, which isn't so necessary in high-income countries, but in settings where survival is low currently, palliative care can go a long way to supporting families with a terminal cancer diagnosis. And so all of these aspects of care are important, and we wanted to uncover where are they available and to what extent, just the availability, not the quality factor. So we set out to do a global survey of all known retinoblastoma treatment facilities. The results are at onerbw.org. It's not currently set up to work on a cell phone, but you could look at it later on your laptop. And we also put in a feature for families to search by their own country to find a treatment center near them. Although our initial intention was just to have documentation of where centers were, what they had available, and maybe inspire some research or collaboration to fill in some of the blanks where we might uncover gaps in availability. This is what the map looks like. So we've shown retinoblastoma prevalence around the world based on that estimated 1 in every 16,000 live births. So you can see that the more darkly orange shaded areas have more cases of retinoblastoma than the lighter orange shaded ones. And that's really related to population and birth rate. And so the most retinoblastoma cases per year would be found in India and China. And a place like Canada, where I am, we see about 25 new cases a year. And so you could take a look at what the expected case numbers are. And then each center that registers on the map fills out a survey to, so those are the green pins. They fill out a survey to indicate which aspects of care are available at their center. And you can look at them through the filters on the side here and the toolbar, as well as superimpose all the data from the treatment centers with various other demographic and World Bank sort of filters by region. We collected information from 178 treatment facilities in 76 countries. And you can see just from where those centers are located that the majority of cases are in middle income and low income countries, and the minority are in high income countries, as I showed you in the first bar graph. So that's not surprising. However, the availability of treatment facilities doesn't follow that. So you can see that the minority of patients in high-income countries actually have quite a big share of the treatment facilities and the treatment available, which shows that inequity. So they have much more available services than the low and middle income countries, although there are quite a few centers for middle income countries, and as expected, low income countries, which are the least well-resourced, have the least availability of treatment centers. When you look more granularly at what resources and expertise are available at the registered centers, a more clear picture of availability emerges. So what's nice is that the most basic levels of care, that surgical ability to remove the tumor and to read the pathology, is generally equivalent between low and middle income countries and high income countries. However, I just remind you, this is not an evaluation of quality or any sort of measures of access, just what is available at the center. And then in terms of imaging, so the tools available to diagnose, something as basic as an ultrasound is pretty on par, but the more expensive or sensitive tools like a RETCam or ultrasound biomicroscopy are less available. Management that would save an eye as opposed to surgically remove it is less available in low and middle income countries than high income country centers. And the newer modes of local chemotherapy are even less available. Radiotherapy as well, although available in 62% of the centers, wasn't as high as the majority of the 93% of the high income centers. And ophthalmologists were mostly associated with the centers, but they didn't always report having an oncologist within the center. And that might be an artifact of how we found the centers to participate in the survey to begin with. And in many places around the world, ophthalmology and oncology might not be in the same treatment facility, and so that's managed in different centers. And this might just be an artifact of how we were an ophthalmology-based team looking at and inviting participation maybe from that lens. And then genetic counseling, unsurprisingly, was not as available in low and middle income country centers as it is in high income country centers. And that's because genetic counseling is primarily a profession found in the global north. There's not, it's not an accredited body in many places in the global south, and availability of genetic testing is only now beginning to improve. And so that's just availability, as I mentioned. In terms of quality, you need different approaches. So how do we do that? This is where the Kenyan National Retinoblastoma Strategy comes into play, and how we focused at a national level to try to improve the quality of healthcare services. And so I'll tell you a little bit about this national strategy approach. Essentially, the Kenyan National Retinoblastoma Strategy Group was a collection of clinicians, researchers, and patient representatives from across Kenya who came together in this multidisciplinary group to meet once a year in person and work in subgroups throughout the year on various projects aimed at improving retinoblastoma outcomes. It was started by Dr. Kahaki Kimani in the University of Nairobi. And she and my colleagues at the Hospital for Sick Children met when my colleagues were just on a mission, sort of fact-finding mission in Kenya to meet people who treated retinoblastoma. And Dr. Kimani was starting a retinoblastoma focus group. She was running into some struggles. And so the Canadians and the Kenyans decided to help each other out and apply for some grants to at least get an inaugural meeting of people together in one place in Nairobi to discuss what are the issues with retinoblastoma management, to uncover what the survival rate was, and to uncover the precise prevalence and incidence in the country. Because as I mentioned, the incidence, 1 in 16 to 18,000 births, were based on studies and data from outside Kenya and around the world, their estimates, but nobody had ever done a study in Kenya to actually count how many cases have we seen, which ones survived, where do they go, what's our referral pattern, what are the equipment and resources and human resources available for retinoblastoma care. So what we did on a global level in onerbworld.org, we did at a Kenya level, and then using that data, figured out strategies to improve on the quality of care and ensure that all kids could actually access that care. This is Michel Ongaro. He's a survivor of retinoblastoma who joined the group and helped us also reach other patients to have their voices heard in the work that followed. These photos are what happened at our meetings. So a lot of work, active work and participation, very different than other conferences that you'd expect. The types of individuals that were involved in the core Kenya National Retinoblastoma Strategy Group in this inner circle were academics, representatives of the Kenyan government, such as the Director of Ophthalmic Services, who sits in the Kenyan Ministry of Health. We had representatives from a local NGO focused on eye cancer, linked to a UK and Canadian branch of that NGO. As I mentioned, retinoblastoma families and survivors and healthcare workers. The majority of individuals were Kenyan, with some Canadian and UK participants, but we were in the minority. And these individuals, as I mentioned, were all focused on improving retinoblastoma survival. Over the years of the strategy's work, we also had some transient support. So vision and cancer NGOs that were aligned with our mandate and the projects that we were generating would come in and support some of those projects as collaborators. We had students from the University of Nairobi and the University of Toronto come in for a summer and help on a research project or a capacity building project, as well as visiting healthcare workers and academics who might have popped in for some training or from some specialized research support. And so this is what our group sort of looked like in terms of who we were. The meetings ran annually from 2008 to 2015. We met for 3 to 4 days, about 50 people at a time, and we worked in smaller subgroups. You can get more information on how this group was formed. The NGO I mentioned, Daisy's Eye Cancer Fund, rebranded into World Eye Cancer Hope. And so there's a history of the group there. And basically what we did in these meetings were discuss, debate, really hone in on what the challenges were from the perspective of the healthcare workers, the government representatives, and the patients. And we designed plausible and evidence-based solutions, and we'd review our progress over each year. And so we really focused first on developing a common set of protocols and guidelines for how retinoblastoma was to be managed. And we did that through a subgroup of our group focused on medical care. So this medical care group focused on adapting evidence from other clinical guidelines around the world to the Kenyan context. What can be done, what cannot be done, what's an optimal referral pathway here. We focused on gaps in clinical training. So one area was that there was no ocular pathologist. So we strengthened pathology in the country by training an ocular pathologist and creating a system of centralized histology for retinoblastoma in Nairobi that all our peripheral centers could access. Genetics was not a priority at the beginning, but as we started to see gains in patient early diagnosis and survival, we started to develop practices that we could, at least in the absence of genetic testing, try to guide our families to understand the heritable consequences of retinoblastoma. We also had a subcommittee on awareness. And so this is where the government representatives were really instrumental. So the director of ophthalmic services at the time of joining our group was developing the ophthalmology material that would go into the maternal and child health book. And this is a booklet that's given to new mothers when their baby is born. And it outlines all the well baby visits. And the ophthalmology pages indicate what are some important things to be looking for in terms of vision health in infants. And so we were able to put some awareness information about the early signs of retinoblastoma in the booklet that would alert both the parent and the nurse at the well baby visit to be aware of what leukocoria might look like. We also did national poster campaigns and radio shows to raise that public awareness of retinoblastoma so that families might hear from somewhere that this was what retinoblastoma was and what to be aware of. At the time of starting the strategy, there was no national health insurance fund for Kenya, and so all cancer treatment was out of pocket. So working with our NGO partners, there were some microfinance initiatives that were started to help mothers with patients in the oncology unit make some extra cash through some beadwork and partnering with some of the tourist shops. About midway through our project, the National Health Insurance Fund kicked in and all inpatient care was covered by the government. So that was kind of nice. We didn't need those microfinance initiatives anymore, but the NGOs that were helping us with that would guide the families in how to sign up for the National Health Insurance Fund so they could ensure to be covered. This family support group also looked at enhancing child life support. As I mentioned, that's part of psychosocial care that focuses on the child's well-being and their understanding of what's happening. In a setting like Kenya, where perhaps we don't have as much access to human resources or even other pharmaceutical support, teaching children what's going to happen and helping them to be compliant with medical procedures reduces the need for maybe an extra nurse to hold on a child during a blood draw. You increase compliance with the children being partners in their care. And so we trained child life specialists who understood retinoblastoma and could support the teams with their techniques. And another group looked at housing. In North America, we have things like the Ronald McDonald houses that allow families to stay close to the hospital when their children are getting care. That didn't exist in Kenya. We did have a team looking at how we might get that, and that's still ongoing. That's a longer term project. And then finally, how do we actually do this without resources? So engaging policymakers was a really big part of getting that in-kind support. For example, the maternal child health booklet didn't cost us anything but time. We did apply for grant applications both locally in Kenya and in Canada, which supported some of these work through the research lens. We worked with entrepreneurs and partnered with local NGOs to really maximize the resources available for these annual meetings and the projects that we ended up implementing. So here's some of the outputs of this group. So as I mentioned, clinical guidelines and adapting existing evidence to the Kenyan setting was a big part of these annual meetings, right down to the point of discussing the wording of the guidelines and tweaking them in real time to come to an agreement. They were published by the Ministry of Health in 2014 and guide management of retinoblastoma in Kenya to this day, although it's time to update those a little bit with new evidence and new abilities, even in Kenya. We conducted research and identified the incidence and distribution of retinoblastoma in Kenya, which did match the estimated incidence from other studies. The retinoblastoma referral pattern and the way patients were referred between sites was uncovered, and survival pre-starting our strategy was documented to be 30%. I'll tell you a little bit about developing the clinical cancer genetic services in a little bit, but this is just to say some of our early work looked at what perceptions were around developing genetic services in Kenya for retinoblastoma. And our strategy, our Kenya National Retinoblastoma Strategy, was published in the journal Globalization and Health to really show what all these different subcommittees within the group, how they worked and what we were able to accomplish with a little bit of international partnership and a lot of local Kenyan work to really improve the situation on the ground. Since publishing that, a master's student at the University of Nairobi has documented the survival rate now in Kenya, and that has risen from 30% to 70%. The age at diagnosis for bilateral retinoblastoma, so that delay in diagnosis I showed you at the beginning, for bilateral retinoblastoma patients has decreased from 24 months to 16 months of age. So that's more in line with what we see in high-income countries. And also for unilateral patients, it's decreased from 35 or 36 months to 24 months of age. Again, decreasing trend that is now starting to match what we see in Canada and the USA. So it's very difficult to achieve something like this. Of course, it's going to be even more difficult right now to sustain this. COVID-19 has posed huge challenges for the whole world in terms of cancer screening and diagnosis, and early reports are showing that we are getting later diagnoses of all cancers during pandemic. And so we need to really focus to make sure the gains we've seen aren't lost with the current situation. Any questions yet before I go to the projects focused on genetics?
I was just curious, what were the total costs over the years? Which you're able to share with us. I was curious, what were the total costs of this project over the years?
It's a little bit hard to say total costs. Let's say each meeting was supported with small grants from $5,000 to $7,000. So to bring those 50 participants and have a conference for 3 to 4 days in Nairobi or Mombasa, where we and pay a small per diem, was maybe $5,000 to $7,000 per meeting. Project I didn't tell you about, which was the centralized pathology service. We got a grant to implement that and study that. That was $100,000 for 2 years. The in-kind costs, we've never actually seen what those were. So we did get a big grant for student exchanges, and the students who did the bulk of the research, both in Toronto and in Nairobi, was supported by a big grant that covered their research exchanges and things that don't necessarily build on our project, but build on their, they build on our project with the staff time of these students, but the costs were bigger because of the travel needed for them. So we had a grant that was $400,000 over 5 years to support the 20 or so students that took part in the exchange. So those are some idea of the cost. It is expensive.
But I guess from a 30,000 foot view, you achieved 30 to 70% increase in survival with actually reasonable costs, I would say.
Yeah, I think it is reasonable, especially you need to maybe look at some of the costs were more because we're an academic partnership. We're investing also in the education of the individuals. So that will yield more benefits over time. And when I'm thinking about these students who did the exchanges from Nairobi to Toronto, what's exciting about them is they learned about genetic techniques they now can take back and start thinking about for Kenya. They learned about biobanking as we're getting ready to study tumors and what the molecular composition of retinoblastoma is in Kenya. All that will pay dividends later on as well. So it's a little bit hard to tease out all the costs of everything we did just to this result, because I think we still have results to see going further.
Yeah,
But
that's very true.
the true answer is I don't know. I don't know. Any other questions?
Hi, this is Josh Palmer.
Hi, Josh.
Really enjoyed your talk so far. So I was wondering, you've made such a huge improvement in Kenya. Is there any sort of an idea to broaden to other African nations?
That's a great question. So during the duration of the Kenyan Strategy Group annual meetings, the team in Uganda invited some Kenyan delegates to launch a strategy there. 2 years ago, Ethiopia launched their own strategy. And another colleague in Ghana is developing her own national strategy. And she was invited to attend the Ethiopian strategy to learn where the Kenyans were. So there's a lot of African coaching, I guess,
Yeah.
among the teams in East and West Africa. There is a lot of collaboration and coaching happening that's leading strategies to be born in each of those countries, and of course aligned with what's possible. Ethiopia got off to a great start. However, I know recently with some political instability, they've actually had to slow down some of the things that they were doing. There was a lot of great support too from Emory University in training some individuals in Ethiopia. The strategy in Ghana, led by Dr. Vera Esserman at University of Ghana, she's actually a real go-getter. She has a number of Canadian and American universities supporting different aspects of the strategy, which is actually really fantastic to think about, because each retinoblastoma team has a different expertise. So that, a team from, I think Ohio, Dr. Aaron Singh, he's been advising them on establishing local chemotherapy. The team in Toronto is really coaching them on the overall strategy development, along with the Kenyan colleagues. There's a lot of exciting things happening. So
yeah, I guess it would be interesting to see if somehow that could be harmonized, because it sounds like there's a lot of different groups doing things
it does
slightly
sound,
differently.
it's true. And, the London School of Hygiene also has a fantastic initiative where they host an online multidisciplinary tumor board for retinoblastoma. And so they're working with the teams in Uganda, in Kenya, in Zimbabwe, I think. And so I'm always one of the people who wants us all to work together. So I try to have my foot in everything. The truth is, when you're in a low resource setting, you'll take all the help you can get. So I have very strong thoughts on our responsibility as high income countries to help rather than, try to benefit by being the strongest partner, laying a stake or a claim on someone. I think if we can help and follow the leadership of our partners in whatever setting that is, Kenya, Ghana, Ethiopia, as long as they're leading, we can support in a way that they think is best.
Yeah, that makes sense. Has anyone ever approached the Gates Foundation to see if they would be interested in this type of public health initiative?
Gates Foundation has been a goal of ours for many, many years. We've had some applications go in, but nothing come out of it. I know my colleagues in the Center for Global Child Health who work in maternal child health and nutrition have a lot of success with the Gates Foundation. I think retinoblastoma is often misunderstood as something that doesn't affect very many people, or childhood cancer in general has that issue. You're too niche, it's too small. But we really need to look at it differently. If you really just think about what this one tiny retinoblastoma has given the field of cancer genetics and tumor suppressor genes, it launched so much research and so much discovery that's leading us to better cancer outcomes to this day. So I think if we can think about even rare diseases, rare-ish, it's not so rare if you're in Africa, like retinoblastoma, as able to answer questions beyond just the field, then maybe we can gather some support.
Because I wonder if they would be even more interested if you could somehow harmonize and propose like a total Africa initiative. Because I wonder if part of the issue is if they may not be as interested in a single country versus an entire Africa initiative where you,
Absolutely. That's a great idea.
because it sounds like you've a lot of knowledge of the different things going on throughout East and West Africa. I think that would be something that I would love to see, is that someone goes forward and creates a kind of harmonized low resource setting retinoblastoma initiative, because you could make a huge improvement throughout Africa based on what you've done in Kenya. It sounds like you could make a huge impact.
Absolutely. And I think leveraging the network that we sort of launched with onerbworld.org,
Mhm.
it's interesting, an offshoot of our map was the first sort of global retinoblastoma study led by Didi Fabian in Israel in the London School, that we just looked at 1 year to 2017, what was the presentation of retinoblastoma around the world. And so all those centers that, declared, yes, we treat retinoblastoma publicly on this database, were then invited to a really cool study. So that's one example of even just gathering very basic data on a large scale. We can do it. And I think, as you say, we could grow to this type of implementation science work as well.
Yeah.
I think Andrea.
Dr. Arna, do you have a question?
Yeah, I had a quick question. Again, wonderful talk. I'm another radiation oncologist that works with Dr. Palmer as well. It's kind of along the same lines. What I tend to hear when I'm talking to different people about trying to improve some of our global health and global oncology efforts in Africa is a lot of the same key players all the time, like Kenya, Ghana, Ethiopia, Tanzania, or Rwanda. But there are a lot of different countries in Africa, as you're aware, and a lot of different, a huge diverse culture. What are some of the barriers that have, I mean, do you know if there's been some work to, as Josh suggested, to bring in some of the countries that seem to be less frequently involved when you hear about these efforts? And again, I think part of it does tie into, like you were talking about, a little bit of large groups going in and kind of laying claim to an area and providing the majority of their support to this primary location. And so you constantly just hear the same main countries, but there's just as great of a need, if not more, in these other areas that aren't being reached.
It's true. I think one factor that might be more Canada or Commonwealth specific, there's a lot of funding provided to Canadian or UK investigators when we partner with other Commonwealth countries. And certainly, the Queen Elizabeth Scholars program funded some of my student exchanges, and the requirement for me was that I had to partner with a Commonwealth country. Kenya's a Commonwealth country, very easy to do. And London School of Hygiene, I think if you looked at their partners, it's probably along those lines. So sometimes we get sucked into these political, pushes and pulls because we have to follow the funding. But I do agree we need to be a little bit more aware of how, are we leading this or are we following? And we may be leaving out some very important and less resourced areas that could benefit from support and inclusion and not be left behind. So funding is definitely one of them, and maybe we need to do more advocacy on that lens. Another thing is, I think we need to also be willing to do more work. As we mainly hear these main players, they've grown in capacity. They know how to work with international partners. It's very easy to work with the University of Nairobi when my University of Toronto has had previous dealings with them. We know how they work. We can figure out a memorandum of understanding, whereas maybe a less resourced academic partner is just starting out, doesn't have a research ethics board, doesn't have other resources that might make our partnership smoother. So we need to maybe think a step before the implementation and the research and the capacity building, and think, can we actually support these institutions for eventual partnership by seeing what other areas they might need some enhancements in.
Yeah, I think that would be great, a great endeavor to try to support. Thank you.
Yeah. Great.
If I may read a great question from Rachel Taylor. Can you talk for a moment on the efforts to get the government buy-in for a particular focus and cause in Kenya? It seems it's been incredibly effective.
Yeah, I think sometimes it's also getting the right people. Dr. Michael Gishangi, who's the director of ophthalmic services, is just a really keen person. It was a little bit of luck because when we arrived to begin the retinoblastoma strategy, Kenya was busy developing their Vision 2020 strategy. And so they were already keenly aware of retinoblastoma and kind of interested in looking at that. Another thing that's helping us up now is that the World Health Organization has started a global childhood cancer initiative, and they've identified 5 sort of key cancers to focus on, low-hanging fruit, and retinoblastoma is one of them. So now with the WHO having this focus on retinoblastoma, that's another added tool to get other countries sort of thinking about what should we focus on in our own cancer control strategies. And the last meeting I was at of the African Organization for Research and Training in Cancer, there were several government representatives from a number of African countries working and sharing their cancer control strategies, and all of them had retinoblastoma on their strategies. So that goes a long way too, just that political will and the alignment with the World Health Organization. So that's kind of nice. When we started in Kenya, I think Michael Gishangi was definitely a unique individual who had interest. And so we didn't have to convince him much, and he did a lot of the work convincing his colleagues.
Thank you so much.
You're welcome. I see that it's almost 6, so I won't go into the second half of my talk. I mistimed that, but I'm happy to take some more questions.
You're welcome to unmute if you have a question. One of my questions in the meantime was, do you see any role for telehealth in the realm of retinoblastoma?
Yes, in fact, even in Canada, not telehealth so much as online multidisciplinary tumor board. So even in Canada, we have a monthly call with all the retinoblastoma treatment facilities across the country. We share our cases, we discuss best practices, and look at how to change things. And I think there's a role for that everywhere, especially now with COVID-19 and not being able to have online meetings. So the London School of the London School of Hygiene and Tropical Medicine, they have started an online RBNet consortium. And once a month, they focus on a multidisciplinary tumor board in a different African nation and offer support for complex cases. When we started our centralized pathology service in Nairobi, that was also built upon a digital pathology system. And so a pathologist in Eldoret or Meru sending a specimen to Nairobi would send so by courier, the lab would process it, stain, take an image, upload it online. Although we didn't have as much real-time uptake sort of from looking at the images from clinician to clinician, they would read the report. We did manage to use the digital pathology system for rounds to discuss cases sort of together and see what was happening in terms of pathological staging of the surgically removed tumors in the nation. And so that was really helpful for education and changing practice when necessary. It might also have a good support for genetic counseling. I know there's a lot of innovation happening from the sickle cell research in terms of counseling through text messaging and using sort of online platforms to communicate important health messaging to patients. So there's a role for that as well.
I see. So the technology is being leveraged all around really the system, from pathology to communicating with patients. And I was curious, you mentioned that initially the assumption was that the incidence is 1 in 1,600?
16,000 live births.
16,000 live births. So what was the actual one once you did
the proper survey? 1 in 17,000, so fell within the range.
Within the range. Okay.
There are some publications that seem to suggest that the incidence is higher in low and middle income countries. There's a paper that came out from Guatemala, but I'm not sure that that's actually, that hasn't been validated by any other study. Most experts would agree it's a constant incidence. We don't know what exactly causes that mutation in the RB1 gene. It's sort of a random event that likely happens uniformly, although it would be interesting to do, you know, like I've always wanted to look around the world and see if there's any, you know, temporal or spatial changes to retinoblastoma incidence that might give us an idea of that initiating event, if it's more common in some areas or others.
Has there not been a GWAS done on these?
Sorry,
This seems like a perfect. Has there been a GWAS study done? A genome-wide association study?
Retinoblastoma, it's very clear that the initiating factor is the loss of the RB1 gene. So having one mutated allele in your germline predisposes you to retinoblastoma, most often in both eyes, sometimes in one eye. And there's several other genomic events that lead to malignancy. So that loss of RB1 leads to the benign form, retinoma, and then other genomic events lead to malignancy in almost 99% of the cases. It's very rare to just sort of stop at the retinoma stage, although some rare cases do. Yeah.
I see, thank you. Any other questions at all? Feel free to unmute. All right, looks like that's it for tonight. Well, thank you so much for a fantastic talk. I learned a lot from you, and I appreciate your time and wish you a lovely evening in Toronto, and maybe we'll see you one day again.
Thank you so much for the invitation. It was my pleasure to speak with you. I'm happy to answer any more questions if you'd like to email me, helen.dimaras@sickkids.ca, and maybe we can even collaborate on something someday. So thank you.
And it will be fantastic. Thank you so much.
Okay, bye-bye.
Have a good evening, everybody.